We'll talk a little bit about non-convulsive status, as a topic with which everyone in this audience is pretty familiar. I just want to touch on a few points here. I've been a consultant to Ceribell for quite a while. So what is non-convulsive status? Well, it's a prolonged seizure with minimal or no clinical manifestations, hence our inability to routinely diagnose it by physical examination. The patient might have just what we've called altered mental status, a term I would love to get rid of. Might have fluctuations in behavior and level of responsiveness, occasionally little bits of myoclonus, especially around the eyes and the mouth, maybe the fingers, and sometimes automatisms as well, things that are commonly overlooked by people who are not really searching for them. Or you may have absolutely no change in somebody who was already comatose or confused. I think that leads to one important observation over the years I've made, is that just because you think you know why someone's comatose, you don't know whether or not they're seizing. You know, that's, I think, the bottom line for me in these patients is that I'm not an EEG machine. I can't tell when I examine the patient whether they're in non-convulsive status. So our awareness of it is increasing. We'll talk about that in just a second, but because you could confuse this for so many other things, unless you do an EEG of some sort, you don't know that they're not in non-convulsive status. Now, recognition is increasing. This is a growth industry here. I don't know that this means anything about the incidence of non-convulsive status, just that people are publishing on it more. We go back to some of the earlier work here that presaged what we do now. And this is now looking at patients who were getting some EEG recordings done, not necessarily continuous monitoring to start with, but when you look at what happened in terms of the duration of seizure activity compared to the outcome of the patients, this is of course always confounded by the etiology of the seizures, but you can see how dramatically the mortality and disability increase if the seizure is allowed to continue. Dan Lowenstein and Brian Aldridge looked at this issue in San Francisco, where they were able to link records from other institutions and showed that the likelihood of responding to first-line treatment decreases dramatically as time goes on before you institute that treatment. And this, I think, is really crucial. Whenever we look at the effects of drugs on the treatment of status, the duration of status is probably the most important single variable with which we can actually intervene in terms of getting response. The sooner you treat, the faster. So, you know, give early and often. I'm from Chicago, that's how we vote. If you look at conditions that are commonly encountered in the neuro-ICU, like subarachnoid hemorrhage, the seizure burden is actually quite important in predicting outcome here. So this study showed that after adjusting for other measures that predict outcome, the seizure burden was strongly associated with both functional outcome and cognitive impairment at 3 months. And you can see on the left side here, which I can't possibly read on the screen, that the probability of a poor outcome goes up dramatically as time progresses. Now, Paul, a long time ago, showed that each seizure in an intracerebral hemorrhage patient increases edema in the perihematomal region and increases midline shift. So if you look at this, there were these three categories where you had increasing amounts of edema as a consequence of these seizures. Now, these are not things that are producing any systemic complications. This is not people got anoxic and therefore had more edema. It wasn't the fluctuation in blood pressure. It was simply more seizures meant more midline shift. Paul's group also showed that the seizures can produce metabolic crisis, so a change in lactate pyruvate ratio examined by looking in microdialysis data. So the more periodic discharges you had, the more likely you were to develop this metabolic crisis. If you look in the central shaded area, you can see that you're having an increase in the LPR, and then during the period where you're not having periodic discharges, it falls back down into the more normal range. This is just another way of exploring that in a larger group of patients. During the ictal epochs, the problem with metabolism, the metabolic crisis, is increasing dramatically based just on having seizures, all other things held equal. So these seizures are very prevalent. This is a number of data sources combined, looking at the likelihood of non-convulsive seizures following a convulsion, up to 48% in some series. Patients with usually primary brain tumors, but also, as we've seen with metastatic disorder, having an incidence between 20 and 40%, trauma, etc. You can see the likelihood of these things. These are all conditions in which we'd like to have some way to improve outcome, and one of the ways to improve outcome is probably earlier recognition and treatment of these seizures. And it also points out that the majority of the seizures that are occurring in the unit are not convulsive, right? It'd be easy if everybody had some sort of convulsive movement to detect seizures or not. Finally, we have had some guidelines with which I've had the opportunity to participate. And most people in this area think that we should really be attaching the EEG to the patient very quickly, but as you'll see, the likelihood of being able to do that is quite problematic. So with that, who's going to be next now? We'll bring up Dr. Paul Vespa. I'll let you skip on this.